As Pediatric Committee, we are more than happy to contribute to this World Smart Medication Day event. After all, at least 20% of humans are children, and the topics of this year's event are of obvious relevance for children as well. I'm Karel Allegaert, and this presentation has been co-created with colleagues Saskia de Wild and Catriona Wade. A lot of extrinsic and intrinsic factors can apply also to children when reflecting on, say, pharmacotherapy. And some are actually already present in the slide, like age and body weight. However, others need perhaps some conversion to pediatric meaningful aspects, like, for instance, puberty or developmental pharmacogenetics or ancestry. And furthermore, it's perhaps also useful to consider that smoking habits are not limited to first-hand smoking, but also secondary or third-hand smoking can have impact on pediatric health as well. And exactly the same relates to environment and, for instance, fine dust pollution. If we start with perinatal life, it's clearly shown that a clearly proven effective intervention in the first world does not necessarily translate in a similar effect in low and middle income settings. Antenatal corticosteroids turned out to be less effective in the ACT trial, illustrating the complexity of simply translating a practice within a given structure to another region of the world. And exactly the same has more recently been illustrated for therapeutic hypothermia, who also failed to confirm the effectiveness in the first world in low and middle income settings. If you subsequently shift to nutrition as one of the extrinsic factors, we already mentioned, obviously, that breastfeeding has variability in practices throughout the world, in part also driven by region-specific socioeconomics. This slide reports on the number of medicines assessed by FDA related to potential impact of obesity. In the long run, it turned out that 13 of the 97 labels were adapted for obesity, but in fact, only in one of these labels there is information on children available. On the other side, related to undernutrition, it's already quite well known, as illustrated, for instance, by the Verelst review mentioned below, is that the pharmacokinetics will dramatically change when the child is in undernutrition state, related to both absorption, volume of distribution, as well as metabolism and elimination characteristics. It's important hereby to realize that children, because of their proportionally higher caloric needs, they are more sensitive to food shortages or disruptions. To shift to socioeconomic inequalities, we wanted to use the pediatric asthma as a well-known and described modulator of asthma control. And as you can see on this perhaps busy slide, but both this relates to management, outcomes, but also in part related to maternal and child health outcomes and exposures that all co-affect the final poorer control. This is not only proven on a country and regional level, but even within cities. You can actually illustrate that underserved parts of the cities will also will be associated with poorer asthma outcome for children. Besides nutrition and other factors, we also wanted to highlight developmental pharmacokinetics as another example of one of these factors. They may be of relevance when considering, say, pharmacotherapy in children. Obviously, similar to other populations, pharmacokinetics or pharmacogenetics can be instrumental to guide your practice. However, you have to hereby consider ancestry-dependent patterns, because some deficiencies listed over here are more prominent in some specific regions of the world. Think about glucose 6-phosphate and acetyltransferase deficiency and all the other examples which are listed over here, are more prominent in given regions of the world and therefore also resulting in potential more toxicity or in inadvertent events. Important also to integrate is in pediatric pharmacology is also aspects related to pharmacoepidemiology. And just as one illustration, aminoglycosides are relatively commonly used in newborns to, to treat suspected infections, but in the Asian population is a specific sensitivity to hearing loss. And the same you can use for carbamazepine and specific pediatric epileptic syndromes. So to wrap, what we have tried to illustrate with specific examples that yes, there's also ethnic and socioeconomic aspects related to pediatric pharmacology, and the art will be to have data, preferably from clinical trials or real-world data that are sufficiently inclusive, so that we know the different covariates involved, and in this way can use available information to guide our practices in every individual child. And hereby would like to thank you for your attention.